So a couple of notes. You'll notice the pop-up window about this session being recorded, so just go ahead and click continue there. Also, if you have any comments or questions, feel free to put that into the chat box. I'll be monitoring that along the way. I will try to get to as many comments or questions as possible, but sometimes we just may not be able to do that. So again, good afternoon, everybody. My name is Mark Duncan, and I'm an addiction psychiatrist here at the University of Washington and part of ADI, and part of the technical assistance team for the opioid grants across the state. I've been doing we're in the middle of a four-part series on psychiatric, on kind of more advanced psychiatric needs in OUD populations and a little bit more broader SUD. And today we'll be talking about managing benzodiazepines and stimulants in my patients with OUD. So let's get started. We'll talk about begin by acknowledging that as we gather today, we are on ancestral homelands of the indigenous peoples who have lived on these lands since time immemorial. All right, so as a review, a couple of weeks ago, we started with diagnosis. We talked about specifically schizophrenia, bipolar, and ADHD. Severe mental illnesses diagnosis should be confirmed to help determine the appropriate ongoing treatment course. You'll get a lot of people will come to you on a bunch of different meds, endorsing many different diagnoses, and hopefully you'll catch your breath when you see that and take some time to get into each of those diagnoses to really give you an understanding of whether or not medication treatment for those is indicated. Oftentimes you're going to need a careful review, and that includes over a longitudinal, that may take over time, both looking back in the patient's timeline, but also just maybe several sessions. And you may need to continue their meds for a period of time as you kind of sort that out. But I will definitely encourage you to do that because it will help really guide you in knowing what you need to maybe continue or what can be stopped. And we'll get into that a little bit more next week. And then last week we talked about using the standard approach for med selection for bipolar and schizophrenia. There's no real specific algorithm for people with OUD when you're prescribing meds in those scenarios. Bipolar and schizophrenia will likely need long-term medication treatment over the person's lifetime. And then you're going to be wanted, there's lots of different side effects with both antipsychotics and mood stabilizers that we went into. And you want to find basically, the lowest effective dose, but even still, you're going to want to find those. And because of those side effects, these aren't meds that I would necessarily just pull out on a whim. Every time you're starting an antipsychotic, which, these days I often see maybe used for sleep, those have some very significant side effects and would not be ones I would want a person to use unless I really had a good indication to use them. All right, so this week we'll be talking about stimulants and benzos. We're going to talk about the different ones available and how and why they are used. We'll be talking about some common side effects, how to monitor for them, improving some of the providers' approach to using stimulants and benzos in mental health disorders in the context of OUD. All right, so here's a case. 35-year-old female on buprenorphine naloxone, 12-6 milligrams once a day for OUD, severe. She's been in treatment for 3 months and doing fairly well. She is housed and working part-time in retail. At the time of enrollment, she was taking illicit benzodiazepines and agreed to stop using them. However, she has continued to use them, and every urine drug screen has been positive for benzodiazepines. She reports to having too much social anxiety without them. So here's a few options. What would be your next few steps? You could kind of cut the buprenorphine dose in half to reduce toxicity potential. You could taper and discharge the person from the program. You could send a residential treatment to get this benzo thing kind of nipped in the bud. Or D, continue prescribing bu for further mental health. Or E, ask her for her dose and just start prescribing the benzodiazepines and avoid maybe the issues of her getting them off the street and potential consequences of having some fentanyl laced in there, who knows what. So maybe take a minute, take a couple of seconds and chat in what you would think about doing next in a patient on buprenorphine also using illicit benzos. And despite what she's saying, or maybe her best efforts, she's continuing to use. Okay, so we got someone talking about maybe D, some E's, all right. D, maybe E. All right, A, cutting in half, reducing toxicity. All right, great, thank you. All right, so we are going to, let's get into this a little bit. So what we'll kind of do is I'm going to kind of talk a little bit about where our concerns with buprenorphine and benzos, kind of look at the risk, get a good sense of kind of the risk of benzodiazepines and buprenorphine, and then we'll get into some of the reasons you may or may not use benzos and how you would kind of think about using them in general for psychiatric, but then in the context of OUD. You know, I think one of the things that's pointing out here is a lot of, certainly when we talk about benzos and buprenorphine, the tendency, not that long ago actually, was to just, in some cases, not even prescribe buprenorphine. And that has changed quite a bit. We're much more kind of nuanced in our approach these days, fortunately, and trying to kind of weigh the risks and benefits. And sometimes that can be pretty challenging. So hopefully this will help. All right, so let's get into a little bit of the history of buprenorphine and benzo-related deaths. It really kind of came out of a 1998 French case series where there were 6 overdose deaths related to buprenorphine and benzodiazepines. Okay, so this was buprenorphine, the monoproduct. It did not have naloxone as part of that formulation. Many of those cases were either people were injecting buprenorphine IV or they were using massive oral dosages. Okay, so there's not kind of our typical therapeutic dose, anywhere from 8 to 24. And that's where a lot of the initial kind of buzz came from. Now, this can occur at some therapeutic dosages of buprenorphine in the following context, where people are using super therapeutic dosages of benzodiazepines or injecting benzos at therapeutic dosages, or combining it with other sedatives, maybe like alcohol or barbiturates, or maybe some Z drugs like your sleeping aids, Zolpidem, and so forth, or Lyrica, or things like that. So it goes kind of both ways. People can kind of go way overboard on their benzos, or they can go way overboard on the buprenorphine, and that's where we see the risk. And usually, again, these are at and they're usually involved with kind of IV injection. Now, we're cutting the risk down quite a bit with that based on the use of the combination product buprenorphine and naloxone, and the use of that, or using like injectables like Sublocade these days. So there's less chance of having that super therapeutic dose kind of entering the picture. But this is kind of where it's coming from. So a lot of times I will when I'm talking with patients that I'm noticing their benzo use is in their urine. And in addition, while I'm trying to help them come off of their benzos and give them some education on that, I'm also talking through what are the riskiest scenarios of ongoing benzo use, so that they're informed to try to avoid those scenarios if they do end up using benzos. Now, all of that, fast forward up to 2017, and as the opioid epidemic really started to kind of come into the national consciousness, the FDA became aware that that a lot of providers were withholding opioid addiction meds from patients taking benzos because of that concern for the risk of overdose. And so the FDA said, whoa, wait up. If you withholding opioid use disorder treatment is actually placing people at much higher risk than say not treating their OUD and then having them continue to take benzodiazepines. So that was a very significant shift in a lot of providers thinking, because we really hadn't had any kind of federal agency say that, this is, while yes, there are some risks, it is less risky, and treating OUD with methadone or buprenorphine is still the standard of care, and you're not going to really run afoul of a lot of maybe like the DEA or other sorts of really just DEA, that you're doing this, despite the fact that there are risks with benzos and buprenorphine. The other thing was that came out the year later was a fantastic article called "The Next Stage of Buprenorphine Care for OUD," where this was one of the first articles that really looked at the risk of buprenorphine and benzos, and kind of really helped people see that while yes, there are still some risks, it's not as tremendously high as we thought it was. They looked at buprenorphine and benzodiazepine co-prescribing, what was going on in 2013 when they had some data. Up to 18% of people were getting both buprenorphine and benzodiazepine prescribing. But what they saw was that buprenorphine was only involved in 1 to 2% of overdose deaths. So, if the risk of overdose with buprenorphine and benzodiazepines was as high as we all were estimating, and I definitely was in that camp, we would have expected to see the number of overdose deaths to be much higher that buprenorphine was involved in, and they weren't. In fact, it was just, again, that 1 to 2% of overdose deaths. So arguably, benzos and buprenorphine, while not an ideal combination by any stretch of the imagination, was not as certain of a death sentence as we were all estimating it to be. And so that really, again, kind of helped shift the conversation, open up providers to recognizing the risks and benefits associated with buprenorphine and benzo co-prescribing, and feel a little bit more freedom to offer treatment and take on those risks, albeit there, but small. All right, so let's go fast forward again to 2020. So we've had some additional data to kind of look at this to really suss out the risk again. So this was an association between prescribed benzos and overdose deaths and buprenorphine discontinuation among people receiving buprenorphine. So this was a retrospective cohort. They looked at lots of data from the state of Massachusetts. You can see 63,000 people that had gotten buprenorphine prescriptions. They were 18 and over. And then they saw, okay, of those 63,000, how many filled at least one benzo prescription? And that was about 24%. Obviously, they weren't necessarily looking at people buying benzos off the street. This was just kind of claims data, PMP data, that sort of stuff. Of those who got one benzo prescription, they had 183 24% had one benzo prescription. Of those 63,000 people on buprenorphine, 183 deaths were related to opioid overdose. Okay, so a very small segment of people who got buprenorphine overdose. Of that 183 deaths, 31% of those people, of the 183, had at least one benzo prescription. So there we are seeing this association again. When you look at what did they actually find from the adjusted harms ratios, so this kind of looks at, what is the level of risk a person has. So they did see that people who got at least one benzodiazepine prescription had an adjusted harms ratio of almost 3. So they were almost 3 times more likely to have an increased risk of a fatal opioid overdose. Now, just to be clear, the unadjusted rate, okay, so this is this adjusted harm ratio can sound pretty alarming. Wow, 3 times higher. Okay, but what does that really look like in the real numbers? And it came out to about 60 overdose deaths per 10,000 person years. Okay, so again, we're looking at a very small increase in risk. It is there, but it's not. It's again pretty small. So this kind of backs up what we had kind of heard. A couple of other points on this particular paper I want to highlight. They did see an increased risk for all-cause mortality, about 2 times. I didn't put the raw numbers there. And interestingly enough, though, they did see a decreased risk of buprenorphine discontinuation. So people that were getting benzo prescriptions actually stayed on their buprenorphine longer than those who did not. They kind of suspect, why was that? It's not entirely clear exactly. They think that maybe the people who got benzodiazepines, prescribing, they were more plugged in, their psychiatric symptoms were being addressed potentially, and so they were sticking in treatment. So if you look at this kind of benzodiazepine bind we often find ourselves in, we know that benzos and buprenorphine can increase the risk for overdose and death. But we also know that buprenorphine and benzos are, by with or without buprenorphine, with or without benzos, are likely going to reduce your overdose risk and mortality versus no medications for MOUD. And we're seeing that benzos may reduce the risk of buprenorphine discontinuation in the guise of treating someone's underlying mental health disorders, which is going to also impact a person's treatment retention. So it's not necessarily just kind of a clear-cut increased risk and no risk. There can be some other signals here that we're kind of looking at. Okay. So a note, and to kind of underscore that point, I just wanted to kind of highlight what an untreated OUD mortality is. The harm ratios are getting close to 30%. So this is, people that are with an untreated OUD are 30 times more likely to die than those who are getting treatment. Now you look at that buprenorphine and benzodiazepine harm ratio. As I mentioned, this paper here was from 2020. This is different than the one I just cited, but there were, we do see an increased risk again, but nowhere near an untreated OUD. So, I think that really, when it comes down to it, the overwhelming evidence supports ongoing OUD treatment, even if a person is on benzodiazepines. And in some cases, if someone needs benzodiazepine treatment, the risk is there, but that may help them stay in treatment, which is going to reduce their overall risk, of course, from an overdose to begin with. All right, so should you ever use a benzodiazepine for psychiatric symptoms in the context of OUD? I would argue try to avoid them. Why? Basically, we're just trying to reduce, so that way we can keep the risk of overdose down. Why would we increase the risk if we don't want to do that? And this is really coming from the fact that benzodiazepines are not the first-line treatment for any anxiety disorder or OCD or related disorders or for PTSD. It's just not. Now, they do have FDA indications, such as GAD, panic, alcoholic withdrawal, seizure disorders, and so forth. And we do use them off-label as first-line agents for like catatonia, agitation in the state of like psychosis or like acute mania. Those are used typically in a hospital type of setting, and anesthesia. And then we'll use them for first-line treatment for inpatient alcohol withdrawal and so forth, catatonia, as I mentioned. There are, and the fact is there are many other choices for anxiety disorders that I would be pulling out first. So if someone is coming to me and saying, hey, I got really bad anxiety, or their GAD-7 is close to 21, and we're finding it very impairing. Benzodiazepines, someone might, it's not uncommon to hear, oh, nothing works as good as some Klonopin, nothing works as good as Ativan. And then you start to take their medication history, and they really haven't had very good trials of all of the other alternatives that we have out there. When I'm thinking about using benzodiazepines, it's way down the list as opposed to some of these. So first-line treatments for anxiety disorders, to be clear, are SSRIs or SNRIs. So that would be things like fluoxetine, sertraline, escitalopram. For SNRIs, venlafaxine, desvenlafaxine, and so forth. You get the idea. Those are our first-line treatments. I'd like to see someone who's been on it for a few months. We've gotten to an adequate therapeutic dose, and before and then kind of having some multiple, going at least 3 different trials between those 2 classes of meds. Now, to be clear, CBT, cognitive behavioral therapy, is really probably our most effective treatment for anxiety disorders. That said, it's always challenging to get, to find potentially. But if you can find it, CBT is going to be something that I would want you to kind of highly recommend. And you can use both meds and CBTs, like you have to wait for one or the other, but really working on these first-line treatments and pushing those is going to be the place to start. Now, after that, there's many different meds that have evidence to some extent or another: buspirone, pregabalin or Lyrica, gabapentin, hydroxyzine, beta blockers like propranolol, atypical antipsychotics like quetiapine, clonidine, prazosin, mindfulness meditation, and other therapies. So, depending on what a person has, say, they have lots of somatic symptoms, or maybe there's like a level of performance anxiety, you might think of beta blockers. If someone has never, is on an SSRI and that's kind of helping their anxiety to some extent, but not a lot, you could augment that with buspirone. And so there's some nice combinations there. Maybe some protracted withdrawal from alcohol or cannabis is part of the picture. So I'm thinking gabapentin, and so forth. So there are some other options that I would definitely be looking at first before going down benzos. We just don't see that risk, the overdose risk associated with them. How do benzos compare to antidepressants? So there's a meta-analysis here of 56 studies, lots of people involved, and you kind of see the effect sizes. So benzos do have a little bit more of an effect size, not a tremendous amount, but do have more than SSRIs. And we see that benzodiazepines are rapidly effective, especially from a short-term use. So sometimes we'll see someone kind of starting, they'll be like, their anxiety is high, we'll use like maybe some low-dose Klonopin scheduled in addition to starting sertraline, at the same time with the idea that we're coming off of Klonopin down the road. That is an effective strategy. Again, in the context of OUD, I really don't see that as being a great option that I would pursue necessarily. Now, maybe starting an antidepressant like sertraline would be helpful in someone coming off of the benzos that they're getting illicitly from the street or wherever. So that might be, an option to kind of talk through with someone and kind of help set them up for that sort of trajectory. But not something I would necessarily kind of prescribe on my, to kind of come up, do that plan prescribing. So benzos do have some effectiveness. Obviously, they have FDA indications, so there is utility for them. Now, what about long-term treatment? We don't have a lot of data on this, but we do have a few that last, for over 13 weeks, which isn't a lot of time, but certainly something. They had compared the benzos versus benzos, lorazepam versus diazepam. You can see that over 4 to 6 months. They found that basically lots of the benzos were equally effective. They were superior to placebo. We saw some sedation and drowsiness. And then the greatest effects were really seen in those first 4 weeks. So that's where a little bit of that strategy of kind of starting them at the beginning and stopping. But again, I really probably would not endorse that in the context of someone's OUD treatment, especially because in many, you may find this in some cases where you're not, where you may be just starting their buprenorphine at the same time. All right, how about so ongoing? So 20 to 36 weeks. They looked at clorazepate versus buspirone, alprazolam versus imipramine, which is an old buspirone. Obviously, we just talked about it. It's anti-anxiety med. It has some serotonergic properties. Imipramine is old TCA versus placebo. Paroxetine or Paxil is SSRI. So all the medications were effective. Efficacy was maintained. Lowest dropout rate. Side effects were with the benzodiazepines, and they tapered after 3 years. They found lower relapse rates after clonazepam versus paroxetine. So what's interesting about this is, again, it does show that benzodiazepines are an effective treatment for anxiety disorders, but due to the context of OUD and that and some of that relapse risk and all the other meds we have, this would be kind of down the road sorts of options around using the benzodiazepines. This is kind of a group of people that I have gotten to know pretty well. They're very consistent in their visits and have really been able to kind of stabilize on their OUD treatment. All right, so what are some long-term take-home points? One, there's very few studies on long-term data. I highlighted a few. There's little efficacy to support long-term benzos or preference for SSRIs. So we don't see, even though people will experience the benefit of benzos quicker, SSRIs kind of catch up over time by 8 weeks. There is greater tolerability with benzodiazepines. There's no, and what's interesting about this is we don't often see a lot of evidence for tolerance. So once we kind of find an effective dose for benzodiazepines, people are able to kind of lock that in and stay at that dose for the duration for up to 3 years, sometimes longer. I've had some patients that have been on benzos for 5+ years, and this dose has really been helpful for them. Now, that said, every once in a while, people do report some tolerance where they're just not kind of getting the same effect as much anymore. And as opposed to kind of trying to ramp up the dose even further, because really don't like to do that, we'll look at kind of exchanging one long-acting benzo for a different long-acting benzo, like going from clonazepam to diazepam. Now, I will also comment that PRN benzos are an even worse idea, are just not a good idea. I don't want to say that scheduled benzodiazepines are a bad idea, because they can be incredibly helpful for some patients with pretty intractable anxiety disorders, kind of on a life-changing way. But the PRN benzos, outside of like using them for flights, I really do not like them. They often, what you basically are reinforcing people is to look for meds to deal with the stressful event in the moment. And it really kind of undermines any kind of development around people exposing themselves to the stressor, realizing that they survived, and having a diminishment of the anxiety symptoms on re-exposure. And people just have a very hard time getting there with PRN benzos. I really rarely use them. The only, and again, within the OUD context, and OUD treatment context, I just don't use PRN benzos. Okay, when would you use a benzodiazepine? So, short-term treatment we talked about. This is, again, I would do this really in some of my more stable OUD patients. When nothing else works. So, including therapy. So have we exhausted? We've gone through 3 or 4 different antidepressant trials. We've tried gabapentin. We have tried hydroxyzine, propranolol, and it's still intractable. Patient cannot tolerate the side effects of other meds or adjunct early in treatment. So this is, again, in the context where someone is going to we're using them early on to help them bridge on to till the antidepressant catches up. Again, I really only do that in scenarios where I know the person very well, and we've tried all these other and I know from their history that they've had a hard time kind of making that jump. All right, so let's talk a little about initial prescribing. So you want to have a clear diagnosis. If you're going to be using a benzodiazepine, make sure that, and taking on the risk of potential overdose, that you have a good idea and a good evidence base to support your prescribing pictures. The other question is how long do you think you're going to be using this? Now, if someone has kind of intractable symptoms and they're and they're not and these have been around for a long time, this may be kind of a lifelong sort of type of picture. And that is a conversation that I'll have with patients. And I'll do this with, honestly, all psychiatric meds, because it's good to kind of have patients know what is the potential there is for ongoing long-term treatment, and the knowledge that coming off of benzodiazepines is hard, especially when people have been on it for years potentially. Lots of times I'll hear people tell me, oh, I'll just take this. I don't want to be on meds forever. I'll just take this for a brief period of time. Fast forward, I'll see the next patient in clinic who've been on benzos for 10 years. That was not what they had initially intended, but here we are. Or they're 80 years old, they've been on benzos for 30 years, and they're having trouble because of cognitive issues and falls. And again, at the beginning, no one thought, oh, we'll stay on this, but that's what happens. And so kind of having that conversation with patients that this is potentially hard and it is hard to come off of is good to do, just so you have fully informed consent. Talking about the risk factors associated with this. So specifically the risk of OUD, knowing like what are the risks, the facts that benzos can sometimes they appear to take at higher dosages, take off some of the ceiling effect around respiratory depression and buprenorphine. Risk factors around increased levels of sedation and falls and accidents are also part of the picture when it comes to prescribing benzodiazepines. And then trying to figure out how will we know this is effective. So I think one of the clear strategies is using a med like GAD7 for ongoing tracking purposes, although to be clear, there's not a solid evidence base around using that tool, but we kind of use it that way. And anecdotally, it seems to be pretty helpful to measuring treatment effectiveness, but also looking at some of their functional level. Are they engaging in their addiction treatment as well along the way? All right, so how about some initial prescribing, how about the pharmacokinetics? So this is something that you're gonna wanna take into account with what you're trying to do. In general, we'll be talking about using longer acting benzodiazepines versus shorter ones, in a sense that the ones that are longer acting have less misuse potential. They're less reinforcing. The shorter acting ones often have a very quick onset of action, which is, when you get that kind of relief that comes on over you like a wave, that's a very reinforcing feeling. And the longer acting ones, it just doesn't have that real spike. And so, if I have someone coming in and they're on a shorter acting benzodiazepine that's scheduled, I'm going to be looking to transition them to a longer acting one that will be helpful for taking them off of benzodiazepines in the future, but also and tapering them down. But also it'll also provide broader coverage for their anxiety symptoms and help kind of keep it entering into that reinforcing category. And then we'll talk about realistic amounts and refills. So early on, in general with benzodiazepines I'm prescribing, we may be kind of doing a week or 2 week long prescriptions, especially if there's a history of substance use. With those that are a little bit longer, it may be without a substance use disorder picture, I may not see them that quickly, but it's going to be certainly within a month, and I'm not going to be sending a lot of refills because I want to make sure see how things are going. All right, and then we talked about the first dose, abuse potential, warning signs for that, whether that's kind of if they're reaching for benzo when using more than initially prescribed, having problems with thinking. I had one patient tell me that we were using we were kind of using benzos to treat his anxiety disorder, where he really had a hard. He noticed pretty quickly with a relatively low dose that his thinking was not as sharp as it had been. He wasn't as well coordinated, and so those were things that we made a quick adjustment on the dose because it was just too much. So one of those things highlights is this lower, starting off at a lower is going to be a better option. All right, so if I had to pick 4 benzodiazepines to use, this would be them, or to be familiar with. These would be the 4: alprazolam, lorazepam, diazepam, and clonazepam. I'll highlight just a few here. So one, they do have FDA indications, so they have been found effective for anxiety disorders. You can kind of see that onset of action. Looking at something like a clonazepam, which has a much slower onset of action, I like that for anxiety, for using that for anxiety treatment. It has a much longer half-life as well, and it sticks around a lot longer, so it helps with kind of a better coverage throughout the day. And then you can kind of see the typical dose range there. So anywhere from, the 0.5 of clonazepam up to 2 milligrams TID, which is on the high end. So if you have someone coming into your office and telling you they're on 2 milligrams 4 times a day, or any dose really above 6, they're in that super therapeutic dose range, the benzos, and you want to have a conversation around the risk of overdose when prescribing buprenorphine. So again, just to underscore, when you are taking someone's history and they're endorsing the use of benzodiazepines and you're starting buprenorphine, getting an idea how much benzos they're using is going to definitely kind of help inform your anticipatory guidance. All right, monitoring. So we talked about regular follow-up, document refills, timing, expected refill date. I'm very clear how long this prescription should last. And in fact, I will put it on the prescription. This should last the entire month. There will be no early refills for any reasons, and literally no reasons. No, I mean, it's like, you know, get a police report if you have to, sort of thing. But outside of that, we'll guard these with your life. Sort of kind of level of security. You don't want to monitor the PMP, so no one's just to check to see if anyone else is prescribing. And of course, urine drug screens. One comment on that is you want to make sure your urine drug screen is picking up the full spectrum of benzodiazepines. Some of the DIPs don't check for all benzos, specifically clonazepam. Most ones that you order from the lab, those will be more sophisticated and do, but the point of care testing may not. So just double check to see if that's there. And then warning signs for those. There's a comment here from Thomas. In our practice, we prescribe controlled prescriptions in 14 or 28-day intervals, so the refills land on the same day of the week, and we don't have to deal with 31-day months. Thanks, Thomas. That is a great tip, because you know, you end up doing a lot of addition and subtraction on the days, and that can get to some confusing pickup times. If a patient is being prescribed both benzos and MOUD, consider having one provider prescribe both. Now, that can be a heavy ask, but if you are, but I have found it when if I can see that this person is on benzodiazepine and they're coming to me for their buprenorphine, and I know I am talking from a psychiatrist perspective here, I much prefer to be in control of their controlled substances than having different providers. I've had different providers do it, where I have worked with other providers when they were doing kind of, one's doing the benzos and one's doing the buprenorphine. And, you know, oftentimes they may not be as careful around the benzos as I would be as the prescriber for buprenorphine. I like to keep close tabs on the dose, know why it's being used, how it's being used. And that just is best facilitated by me prescribing both medications. Okay, so in summary, for benzos, you want to treat the OUD regardless of their benzo use. I think that's clear. There is a risk for overdose. It's small. And the risk for an untreated OUD is much higher. Avoid starting benzos for psychiatric disorders. You have lots of other options. People will tell you that benzos work the best, but we need to kind of go through the other options first, and I would argue for safety reasons. Ambulatory tapers can work. I didn't talk about that very much. You know, this is, you know, maybe you're in the context of, you know, someone who is on benzodiazepines, they're getting off the street, and you're thinking, okay, well, let me taper I'll start benzodiazepine, I'll help them come off of the benzos they're getting off the street. That can go south very quickly. One key feature is they may not stop using benzos they're getting off the street, and now they're using yours and the ones they're getting off the street. The other is you often have a very unclear idea of what dose the person is taking. Now, people will tell you, oh, I'm getting this pill, and they'll tell you exactly what they get. Maybe not. You know, there could be other reasons why they're telling you they're at a lower dose than they really are. They may not even really know, or they may not really know what's in the benzo they're getting off the street to begin with. So it gets very tricky. In general, ambulatory tapers, you know, there is some evidence for that in like patients without SUDs. Within the context of maybe like a SUD, like a sedative use disorder, like a benzo use disorder, and doing a taper in that context. Again, very, very challenging. I've had lots of people not be able to make it. If you are prescribing both, consider doing, if a person is on both, consider doing both. All right, so back to the case. Oh, sorry, transitioning, new case. All right, let me pause there and see if there's any questions about benzodiazepines.
Hello, I'm calling in by phone. What if one of your patients who you've had relatively stable on benzos gave some, you talked about no early fills, gave some of their supply to a dear friend who was, having a hard time, and they come to you in obvious benzodiazepine withdrawal? How do you treat that?
Yeah, that is a great question. We'll see a little bit of that with people give their buprenorphine away as well, too, although they're able to kind of, they usually have a little bit of a stockpile left to manage that. Anyway, yes, it is tricky. So if it's like the first time, I mean, I'll try to give people the benefit of the doubt. I will reiterate my kind of requirements and be very clear that the next time there won't be any early refills, and I will manage their benzo withdrawal with medications like Depakote or there's some evidence around using like blank on the carbamazepine, something that will kind of manage their withdrawal temporarily before their next prescription. And I'll try to encourage them to strongly help the person they're trying to support to get into treatment, because it's just not this off kind of the generosity is just not going to serve this person very well in the end. So, I try not to be too strict, but I do have kind of my own personal limits about it, and that's it. There's another question from Jeremy. What are your go-to medications for severe panic disorder to reduce PRN benzodiazepines? So panic disorder can be effectively treated with therapy, so I'm going to make sure that that's part of it. The other piece is on the antidepressant side. Lots of times I will be needing to go up to more at the much higher end of the dose range. So for sertraline, you'd think of something like 200 milligrams. Sometimes I've even gone a little bit higher, so it's a little bit super therapeutic on the SSRIs to treat the more severe disorders. I will also, augment potentially if the panic disorders have a lot of somatic symptoms, augmenting with propranolol can be useful, and as far as toning things down. But if none of those things work and the patient is kind of hung in there with me and we've tried them and given them a good pass, then I will look at scheduling benzodiazepines potentially. Now, the question is if they have a panic disorder like once a month, would you put someone on a daily anti-anxiety med, whether it's an antidepressant, or maybe it's twice a month, maybe it's an antidepressant or a scheduled benzo? No. I mean, to me, I feel like that doesn't make a lot of sense. If it really is that infrequent, then I will give people a very small supply of something like a lorazepam to do in that PRN scenario. And it is a small supply per month, like 4 or 3, just a backup. But again, really kind of pushing for working on getting involved in therapy, which can be very effective. All right, so here's another case. A 22-year-old with OUDs was on oxycodone, started at 17, smokes weed daily, buys his friend Xanax, takes Adderall for a previously diagnosis of ADHD that he got, I think, in grade school. Look at the PMP, there is no recent stimulant prescription. However, it is positive. He does have it in his urine. He also has the following request. He wants to start buprenorphine for OUD. Yes, let's do it. He wants to taper off the Xanax. Yes, definitely, let's do it. He said he was using Xanax to manage stress of school, and he'd like to have his ADHD treated. All right, so shifting gears here to stimulants and buprenorphine. What are the risks and benefits for using stimulants? Just as a review, ADHD is the most common neurodevelopmental disorder. Adults, it kind of persists up to about 4.5%. People with SUDs often have ADHD. Sorry, that needs to be corrected. 2 to 3, sorry, people with ADHD often have SUDs, up to 2 to 3 times higher rates. So it's very common to see co-occurring ADHD and SUD. It can have a lot of impact on their development, whether that's jobs, relationships, schooling, so forth. So starting points when it comes to prescribing stimulants, I really am honing in on, is the diagnosis correct? I really want to really hold off on thinking about using stimulants in the context of ADHD. I'll limit off-label prescribing. There's some evidence for their use in treatment-resistant depression, but I'm not really getting there with many of these patients until a few steps down the road. Remember, there are no ADHD emergencies. Okay, so if you need some time, take it. Untreated ADHD, though, interestingly, will decrease SUD treatment retention. So it's important to address it. Not take forever. Like, well, we'll get to it in 6 months when you're stable. No, figure it out. Do your due diligence. Take the time that is needed. Yes, it will take time. I had one today. I'm actually calling 2 people later this afternoon to kind of suss out some of the collateral and back history, because it's a very complex case. And what we saw is almost 5% odds ratio of dropping out at 90 days if their ADHD is untreated. Okay, will ADHD meds make my patient's SUD worse? The answer is no. There's no evidence. They've done lots of studies using stimulant treatment, and in none of those cases did it worsen someone's substance use disorder. That didn't always work, but it didn't worsen it. ADHD stimulant treatment has been associated with treatment retention, as I mentioned earlier. The harms ratio was 0.59. They saw that ADHD stimulant treatment was an even stronger predictor for retention versus buprenorphine. So this particular population that I was commenting on at the last slide, they saw that people stuck in treatment longer if their ADHD was treated with stimulants. Is my patient at risk for abusing stimulants? The answer is yes. In particular, you can kind of see the opioid SUD. This is a paper, I think might be a VA population here, so there's some limitations there. But across the board, we do see an increased risk for those who have a SUD to misuse their stimulants. So you do need to be careful around treating ADHD, but I would argue keeping someone engaged in your treatment is going to be worth it. There's a question around history of methamphetamine abuse history, and we will, I'll get to that in a few minutes as we get into treatment. Should abstinence be required? So the idea is should you stop, should you not be on any treatment before, or should you wait till the SUD is they've stopped using and they're before starting ADHD treatment? I would argue that an integrated approach is important. We saw that untreated ADHD has higher rates of dropout during the first 90 days, you would want to start, I would say, always start your SUD treatment ASAP to help stabilize it. Then start your MHD treatment as soon as possible. So basically the question is, what does stabilization mean? For OUD, stabilization to me is really kind of honing in on that dose. So that may be within the first 2-3 weeks. And then, if I've got this ADHD diagnosis figured out, I'll be looking at that. For a stimulant use disorder, maybe earlier. So Christine asked about methamphetamine abuse history. Or maybe they have a current methamphetamine abuse disorder. There is some evidence that using stimulants has been helpful for treating stimulant use disorder, kind of setting aside the ADHD picture. Certainly, if they have ADHD, that's even a better reason to kind of consider it, but in a careful fashion, which I'll talk about. And then, of course, there's going to be variations between patient history and prescriber comfort. Patients who are abstinent, but patients who are abstinent will have better ADHD outcomes. And abstinence should be the goal. I would suggest that this is a marker for ADHD treatment. Some places will kind of hold off and be like, okay, you get a clean urine, or we see some reduction, we will continue this. If you end up kind of relapsing, then you will kind of lose the stimulant privilege. I'm not entirely on board with that. But if someone is like completely off and continuing to use methamphetamine, then I'm not going to be prescribing stimulants. And honestly, the patients who I have done, who I was prescribing like methylphenidate for, and they were back to using the meth, they just told me like, I'm not even using this anymore, so don't worry about prescribing it until I'm ready to stop using meth. It just doesn't make sense. All right, ADHD med treatment effects diminish sometimes in the context of SUD treatment across the board. Sometimes it's no better than a placebo. So you're going to want to temper your expectations around ADHD med treatment. Now, there's questions around, this is a different kind of ADHD animal in SUD populations? Who knows? Is there, maybe there's some neurological effects for prior drug use? Maybe. But there's, again, tempering expectations. Retention will still be a challenge. That said, if more people have more severe ADHD, will have better treatment effects. Other psychiatric comorbidities will reduce ADHD med treatment effects. And then also kind of coming back to the CBT for ADHD. That can definitely be used. And I would argue, CBT is going to could have some, spillover effect into their substance use disorder treatment as well. All right, so let's talk a little bit about pharmacotherapy. First line is stimulants. We see better treatment effects versus non-stimulants such as atomoxetine and bupropion. Favor longer-acting preparations to improve adherence and minimize risks of abuse, and you may need higher dosages. So wait, what about these non-stimulant options not working? So atomoxetine had like 3 studies. One of those studies found that it was helpful in the context of alcohol use disorders, but those who were using cannabis, not so much. So if someone has an alcohol use disorder and they have ADHD, atomoxetine, I think would be a reasonable option. You have some evidence there. Bupropion hasn't been studied much. It was used in one group of OUD patients on methadone. No significant effect versus placebo. I really don't find this very helpful for ADHD in the context of SUD. Sometimes people have asked about clonidine or guanfacine, and there's really only PEDS data. There's no data around SUD. So again, these are going to be kind of down the road. Oh, my ADHD, the meds are kind of working, kind of not. I can't tolerate higher dosages. Okay, I'll try clonidine or guanfacine. All right, how about first line here? So methylphenidate is kind of expert consensus first line treatment. We say this for a few reasons. One, it's you have long-acting formulations. It has a kind of a relatively longer delayed onset of action. It's going to be, it just doesn't have like the potency that we see with amphetamines. Plus, when you're doing urine drug screens, you're going to be able to separate out whether or not a person is using amphetamines whereas if you're using like Adderall, is that meth or is that their Adderall showing up in their urine? That's not something you have to worry about in methylphenidate. We also see some trends around higher dosages. So interesting enough, they looked at low dosages. These are kind of more in the therapeutic range we'll typically use. We really didn't see much significant benefit. In the higher dosages, up to 880 milligrams of extended release, that would be the Concerta. The FDA max is considered to be 72. So this is like way higher. There, actually, they saw some clear, significant improvement. There were some high dropout rates. This was an incarcerated population. This was a context of people who had a methamphetamine addiction, but we saw improvements, some clear signal, much more so than anything at the lower dose. So you're going to be wanting to be at that higher dose range. Now, the next in line, if people can't tolerate methylphenidate or it's not working, lisdexamfetamine or Vyvanse is my next go-to. This is a prodrug, so it needs to be hydrolyzed by your red blood cells to get to the active ingredient, which is definitely reduces the IV misuse potential. People just, you're not, I should say, you're just not going to be able to kind of get that initial reaction like you would if it was like Adderall. I mean, you will eventually get it, but it takes that hydrolysis to happen first before you get its effectiveness. Time to peak is 4 to 5 hours. So it takes a while. You just don't get that if you're to inject it. Long acting, it's a good med, and it's effective for ADHD. That said, there's only one study that has looked at this with adult smokers. This is kind of why it's below the rest as far as methylphenidate. And it did show improvement. But this is a very small study, but this would be kind of my second in line versus say like mixed salt Adderall. There's a question from Jeremy. How do you respond if a patient says cannabis effectively manages their anxiety, ADHD, etc.? It would be interesting. I mean, I would ask are they asking to not be on anything else? There's some interesting data that cannabis does have some effectiveness to help people with ADHD symptoms. Cannabis is a very complex compound. So, that said, it has lots of side effects that kind of undermine what you're trying to do with ADHD. So I will say, okay, well, that's great. Let me know if they really do have ADHD. We'll kind of revisit this and see if they want to try to come off of that med. To me, the cannabis and the anxiety is really more about avoiding cannabis withdrawal per se, or it's helpful for anxiety is kind of in the moment, like with alcohol. In some cases, obviously not quite as, you don't end up with kind of some of the consequences related to it. So, it's a conversation we'll have, but I'll be definitely kind of suspicious that they're getting the full benefit versus some of the medications we could use. There's one study that looked at mixed salts amphetamines, which is Adderall. They used higher dosages again. This was in adults with cocaine use, and they saw that it did actually improve some of the outcomes. All right, some other considerations for ADHD. So are they significant risk of med use? If that's the case, then maybe trying some of the atomoxetine non-stimulants is the way to go. If they have pre-existing medical or psychiatric conditions, so bipolar, stimulants can push someone into mania. So how well is that controlled? Schizophrenia sometimes it can make those psychotic symptoms worse. It can worsen anxiety. Stimulants can reduce the seizure threshold and trigger seizures. Cardiacs, increase your heart rate, increase your blood pressure. These are all things that you're going to want to consider as they are potential side effects from their use. All right, so I know we're at 1 o'clock and I have just a couple more slides here. There is an evaluation link in the chat, so if we would really appreciate you getting some feedback on this session, as we kind of wrap up, get ready for next week and wrap up. Okay, so treatment guidelines. If someone has ADHD, I think it's worth considering stimulant treatment. I would give them a good 4-week trial on it before kind of jumping dosages with the longer acting methylphenidate preparations. And then please don't forget the utility of CBT for ADHD. This is often needed, and because the meds, there's lots of other things that are part of someone's ADHD besides kind of what the stimulant's going to do, whether that's time management, prioritization of tasks, and getting past and developing some of the study skills that they just never may have developed. All right, so with that, I'm going to wrap up here. It's a little after 1. I appreciate your time, and just again, highlight some of the psychiatric consultation resources, the PCL, for any providers with adult psychiatric or addiction questions, PAL for moms, PAL Align for kids, and then the Psych and Addiction Case Conference for any provider interested in didactic presentations and some case-based learning. We do that every Thursday from 12 to 1:30. All right, so there's a question from Christine. Can you view last week's sessions? I'll let Susan and Nicole answer that. But again, appreciate your time, and thanks for joining us today.
All the past sessions are posted on learnabouttreatment.org.